Hey everybody, Dr. Maynard here. Wanted to talk to you a little bit about blood gas analysis. The EPOC system does have the ability to do venous blood gas or a VBG. We're not going to be taking arterial samples. It does have the ability to do an ABG, but we're going to be focusing on VBG. Just a reminder, this is for educational purposes only. You're going to be doing a lot of samples, getting a lot of VBGs back, and I wanted to give you some tools on how to use these properly and analyze the VBG results. This is not in the protocol, so this is for educational purposes only. All right, so acid base. Before you turn off the screen, hear me out. So it's important. It's tightly controlled by a number of organs in the body and buffer systems. Dysfunction of any kind is going to compromise the cells, the tissues, the organs, and cause dysfunction. And so it is very tightly regulated in the body. So what are acids and what are bases? Well, hydrogen ions, or H plus, are basically a single proton. And if you remember from chemistry class, a hydrogen is a very simple molecule. It's basically, or atom, I should say. It is just a proton in the middle and an electron. Electrons are negatively charged, so if you lose an electron, you're left with a proton, which of course is positively charged because the positive and negative charges attract. All right, so you get a hydrogen atom that lost its electron, and so now it's known as an acid. So a positive charge makes it an acid. Basically, a hydrogen ion is an acid. A base is basically something that has a negative charge or has electrons to give to that H plus. And so if they can donate electrons, they may bind together and create a neutral substance when the charges cancel each other out. All right, so pH is a measure of the concentration of how many free hydrogen ions we have, or H pluses. We could have done a different type of pH and measured the base, but by convention, we measure just the hydrogen ions. All right, so the normal extracellular fluid pH ranges is between 7.35 and 7.45. If you wanted to make it easy, some people just remember 7.40 plus or minus. All right, so as the free hydrogen ion concentration increases, we can measure this in the blood. The pH actually goes down. So it's a little counterintuitive. We're measuring hydrogen ion, but it's an inverse scale. And so the pH actually goes down. So a low number means acidic, or in this case, acidosis. And then for the H plus going down or decreasing, it's just the opposite. That's alkalosis, or high pH. All right, so who cares? Well, basically, if you're outside of this range, if you're too acidotic or too alkalotic, you actually can lead to death, as we can see on this chart. So cell death begins when it gets too acidic, below 6.8, and when it becomes too alkalotic, above 7.8. Oftentimes, we'll see patients, with a pH of 7.1 or 6.9. You don't see a lot with 6.5 because they've already expired. All right. So how does our body buffer or keep us in such a narrow range? There are these systems or shock absorbers within our system that if you were to drink acid or something were to happen in your body that would make your blood acidic, it was going to bring you back into the neutral range so that you don't become too acidic. So some of you have seen this equation before. This is the carbonic acid buffer system. And so what is a buffer? Buffer is basically any substance that can alternately bind or release hydrogen ions. So it mitigates the effect of taking an acid or alkali or basic loads. The carbonic acid buffer system is by far the most important, but not the only buffer system in the body. And it's located in the lungs and in the kidneys. So the lungs can hold or release CO2, and we'll see in a minute what that does. And also the kidneys can hold and release bicarb, or HCO3, also known as bicarb. Now remember, CO2 is going to be acid, essentially, and bicarb is going to be base. All right, so under normal conditions, everything is balanced. We don't have an excess of anything. But if we had taken in an excess amount of acid, let's say you drink hydrochloric acid, I don't know why you would do such a thing, but if you did, it would increase the acid in your blood, amongst other problems. So now we have this red H plus. And so what are we going to do with all this extra acid? We need to get rid of it. We need to convert it into something else. So it goes through and combines with bicarb to make carbonic acid, which then dissociates into water and CO2. So that's good because that basically means that we have taken a very dangerous situation, too much acid in the blood, and made it into things that we can get rid of, like CO2, which we can just breathe off. So remember, low pH, there's two ways we can get there, or we can have an acidic environment. That's through metabolic acidosis or respiratory acidosis, and we'll explain those later. Now, what if you don't have enough acid? Well, you can hold on to CO2 by not breathing as fast or taking shallower breaths. So you're not getting rid of as much CO2 with every exhalation. That will combine with H2O, which then becomes carbonic acid and then dissociates. And you can get some of that acid back, bringing you back into a neutral pH. And just as a reminder, when the pH gets too high, this is what we call alkalosis. And there's two types, there's metabolic and respiratory alkalosis. All right, so how do the lungs affect pH? Well, basically, our respiratory rate affects the pH in this way. Carbon dioxide is effectively an acid. You'll hear me say that again and again, and it's not technically true, but it works for our intents and purposes. So remember that when CO2 goes up, you become more acidic, or in other words, your pH goes down in the blood. All right, so an analogy here. If every time we breathe out, remember we breathe in oxygen, we exhale CO2. Every time you breathe out, you're dumping out a bucket of CO2 or a bucket of acid. So if your blood was too acidic, you have too much acid. Remember, through the carbonic acid buffer system, you're going to have an excess of CO2. If you can get rid of that CO2, you'll allow yourself to get rid of that acid. This is why I say CO2 is acid. So as you exhale, you can dump out more buckets of acid. So this is why when patients have metabolic acidosis, for example, DKA, they will breathe fast. This is what's called Kussmaul respirations. And this is why we want to get rid of CO2 because we have too much acid in the system. By getting rid of CO2, we get rid of acid. All right, so if you're too acidic, and for example, metabolic acidosis, you increase the respiratory rate, or for that matter, the tidal volume, and you can get rid of your CO2 faster. And if you had the opposite problem, you have too alkaline or too basic, this is metabolic alkalosis. Basically, we just hold our breath, right? Or hold on to buckets of CO2. We don't breathe them out. We hang on to them. That acid will accumulate and eventually correct that alkaline problem. All right. So when the lungs influence pH or hang on to CO2 or release CO2, we call this respiratory compensation. This is a fast process as opposed to renal compensation, which we'll talk about next. All right, so how do the kidneys influence pH? So the kidneys basically can adjust both bicarb and the hydrogen ion. It has the ability to do both, but as we can see, it's going to be much slower. All right, so if the blood is too acidic, we call that metabolic acidosis. What we can do is increase the amount of base or bicarb to neutralize that acid, or decrease or excrete the amount of hydrogen ions, which of course is acid. If it's too alkaline, we just do the opposite. This is called renal compensation, and this is a slow process. It doesn't happen right away. It happens over a chronic period. All right, so we're going to talk about VBG interpretation. There's basically three numbers that we need to know: the pH first, the PCO2 or partial pressure of CO2, carbon dioxide, and then the bicarb, which is the third number that we're going to know. All right, so remember, just as a reminder, the pH is normally 7.35 to 7.45 in that range. The PO2 I'm sorry, PCO2 should be around 40 millimeters of mercury. And then the bicarb should be about 24. So those are the numbers to remember. All right, so we're going to do this by cases, and we've got a diagram here off to the right side, which will show us how to interpret this. So case number one, you've got a 64-year-old male. He's got a past medical history of ALS or Lou Gehrig's disease, and they present for altered mental status. And we notice that a remarkable vital sign is that the respiratory rate is very slow, only 6 per minute. And that goes along with ALS, right? Because they lose their capacity to control their diaphragm. All right, so what does our VBG show? So traditionally, we see the pH as the first number, then a dash, then the PCO2, and then the bicarb. That's the order: pH, PCO2, bicarb. So our pH is going to be low. So if we go up here to our analysis, pH is low. So we do know at this point, we've established this patient is acidemic or has acidemia. All right, so the next one is we're going to check the PCO2, and we're going to say, is this high or low? Well, we know normal is supposed to be 40, and our PCO2 is high, so we're going to call this respiratory acidosis. All right, and that is the analysis. So it's a primary respiratory acidosis. And just as a reminder, why is this patient acidotic? Remember, they're losing their capacity to get rid of CO2. They can't get rid of those buckets of CO2. So that acid or CO2 accumulates in the body, bringing down the pH or causing acidosis. All right, next case. You have an 82-year-old female, past history of type 1 diabetes, presents for altered and looking dehydrated. All right, tachycardic, respiratory rates pretty fast, 36. Glucose is elevated. Oh, starting to think about something now. All right, VBG shows low pH, 7.27. So that's going to put us down the acidemia route. And then what about our PCO2? Remember, it's supposed to be 40, but it's down to 27. So what's going on there? It's pretty low. So we see that the PCO2 is low. So we're going to call this metabolic acidosis. And furthermore, do you see that the bicarb is also low? And so that is what we call metabolic acidosis with respiratory compensation. So basically what's happening here is we have too much ketones, which are acidic and are causing our pH to drop. So what the body does is it represents that acidosis by a low bicarb. That's what makes it metabolic acidosis. And because we're so acidic, we're trying to compensate by getting rid of acid or breathing off CO2. That's why our PCO2 is low. So what's the diagnosis? This is DKA, diabetic ketoacidosis. All right, case number 3. We have a 24-year-old female, history of anxiety. She presents for periorbital finger and hand tingling, cramping. She's doing the carpal pedal spasm, breathing very fast. And what we find is on her VBG, she's got a high or low pH. This one's high. So pH is high. We're going to call this alkalemia. All right, our PCO2 is supposed to be 40, but it's 24 here. So we're going to say that's a low PCO2. And our interpretation is that this is primary respiratory alkalosis and renal compensation. Why renal compensation? Because what we know is that the bicarb is supposed to be 24, and in this case, it's a little bit lower because it's trying to get rid of bicarb, which is a base, to make the less alkalotic. All right, so this patient is hyperventilating, right? And that's what's causing the patient to become alkalotic. All right, next and last case, case number 4, you've got a 64-year-old male. He's got a past history of CHF for which he takes Lasix, and he presents for vomiting and confusion. So what might be going on with him? His respiratory rate's actually kind of slow. Why would that be? That's strange. And I look at our VBG and we find that the pH is actually kind of high. Remember, we want something around 7.4. And this is high, so we're going to go, our pH is high, so that's called alkalemia. And what we notice is that the PCO2 49, that's actually high because normally we want to have a PCO2 of 40. And so we're going to call this metabolic alkalosis. And so this patient has primary metabolic alkalosis. All right, so that's the end of the presentation. Hope this was valuable. Remember, you're not going to be tested on this, but you are going to be doing lots of VBGs. And so I want to make sure that you understand how to do those and adequately interpret the VBG. Wish you all the best. And if you have any questions, please reach out to me.